Hola. I would like to say three things before I start. Firstly, to say what a pleasure and a privilege it is to be here today, and to thank the organisers very much for inviting me. The second thing is to apologise that I cannot speak Spanish, and therefore I will be giving my presentation in English. So I hope I am speaking slowly enough for the translation to work, and for those of you who understand English to understand me, but I am very sorry. The third thing I would like to say is that what I'm going to talk about today is the situation at the moment at NICE, the National Institute for Health and Clinical Excellence. As you will know, we have recently had a change of government in the UK, and there are some very significant implications both for the work of NICE generally and also about the extent to which we involve patients and the public in our work and in health policy generally. So it's just a small warning that what I talk about today is a moment in time, and I will discuss at the end of my presentation some of the implications of this change in government and what this might mean for both NICE and for patient involvement more generally. So my role at NICE, where I've worked for almost 10 years, is to run our patient and public involvement programme, which is a small team within NICE, which I will talk about in more detail later. And our primary responsibility is to make sure that the perspective of the patient and their carer, and also members of the public, can be represented in all of NICE's guidance products. NICE, as many of you will know, is part of the National Health Service in the UK, the NHS, and it is charged with producing national guidance based on a comprehensive review of the evidence, with the input of health professional experts, with patient and carer involvement, which is the area that I'm responsible for and also the area that I will talk about today. All of the groups that produce our guidance are independent. We have genuine consultation both with the public and with representative organisations. Our processes are open and transparent and subject to challenge, either professionally or from a patient perspective, or even in the courts where need be. We have a very important consideration, which is to take account of groups in society that may be disadvantaged by gender or race or social status, and we have to make sure that the guidance we produce takes into account those people's special considerations, and also that we make sure that they are represented in the work that we do. And finally, one of the core principles of the guidance we produce at NICE is that it's subject to regular review. We are very aware of the rapidly changing evidence base in healthcare, and therefore our guidance does not stay static. It's subject to constant review, and each piece of guidance has a review date at which it will be updated. So, what do we involve patients and the public in at NICE? Well, there are opportunities for involvement in all types of NICE guidance. We have three main types of guidance. Health technologies, which is the use of new and existing health technologies such as drugs, diagnostics, and healthcare devices. We have a very large public health agenda, which looks at trying to produce guidance on the promotion of good health and the prevention of ill health. But the topic that I'm going to talk about in most detail today, and the focus of most of your interest, is clinical guidelines work, which is looking primarily at entire care pathways for particular diseases, conditions, and disabilities. One of the reasons we are able to have such a strong approach to patient and public involvement at NICE is that we have a formal policy embedded into the work of the Institute. And this policy states that the views of patients and the public matter to the organisation, and that we want to involve them, as well as doctors, nurses, and other health professionals and health service managers in our work. And I would say that not only do we want to, but that we very much do. And I will indicate later how we do this and what some of the impacts of that involvement have been. But our policy also states that we believe that by working with patients and the public, and also the organisations that represent their interests, we will try and produce guidance that addresses the issues of concern to patients and the public, that truly reflects their views on what's important and what matters to them, and meets the needs that they have in terms of the healthcare that's delivered to them. And what I will try and indicate in my presentation is that by having the presence of these organisations and these individual patients and their carers, we are in a position to be able to challenge some of the assumptions of both health professionals in terms of what patients want, but also of researchers. So much of what we do is based on research evidence. And when you start examining some of that research evidence in the context of looking at what patients want, sometimes you find that what patients want isn't what's being researched. And that's a really important part of what we do, is trying to identify those unmet needs in terms of research as well as healthcare. So when do we involve patients and their carers and members of the public? Well, it's pretty much at every stage of the development process. And I think from picking up from reading the presentations of my colleagues before me, that this is something that's agreed as a very important aspect, that there is involvement at every stage of the process, that it's not just about consulting with people at the end of a process, but it's about making sure that they're integrated into all stages. So starting from the top, this is a very, very rough schematic of what a development process looks like for a piece of NICE guidance. Anybody can suggest to us a topic that they would like us to work on. And when we last did an analysis, about 42% of the suggestions we got came from people who identified themselves as patients or members of the public. So almost half of the suggestions that we get for topics to work on come from lay people. The only part of the process in which there is no direct patient involvement is the point at which we are referred topics to work on. The topics that NICE works on are determined by the government. They're determined by the Secretary of State for Health. He will take into account the topics that have been suggested to us, and we have a system of trying to prioritise those according to greatest need, where there are a large number of patients affected or where there is known to be large variability in practice. And so we try to filter those suggestions and then we refer them to the government. And then they ask us to develop guidance on particular topics. So that's the only stage of the process in which there is no direct patient involvement. But as soon as we get asked to develop a particular topic, we start to what we call scope that topic. We start to try and put boundaries around what it is that we're going to look at. So we will try and identify what populations should we look at, whether this should be a guidance that looks at children and adults or perhaps just adults, whether there is a particular part of the care pathway that we need to concentrate on. And at that stage, the formation of this scope document, which is the skeleton, if you like, the framework around which the guidance will be developed, we have an active consultative process with a large number of stakeholder organisations, including as many relevant patient carer organisations that we can identify who might have an interest in the topic. And one of the jobs of my team is to try and make sure that each of those organisations who could be interested in this topic, whatever it is, are aware of it and have an opportunity to take part. So at that stage, it's very much about the involvement of people at an organisational level. So it is about the representative organisations. But as soon as we get into actually starting to develop the guidance, when we form the guideline development groups, at that point it becomes much more about the individual patient or carer, as we have representatives of patients and carers on each of our guidance development groups. And I'll talk a bit more in a minute about how we identify those people and how we recruit them to the group. But at that stage, the people on the group are not there to represent an organisation, nor are they to represent the whole patient population with a particular condition. They're there as individuals with their individual experience. And I will talk about how we try and get a balance of those experiences when we recruit. So throughout the time we develop a piece of guidance, we have individual patients and carers working with us. And as soon as we have draft recommendations for practice, we will again put those out for consultation so that the organisations again have an opportunity to comment on what it is that we've recommended. And again, the stakeholder organisations that we consult with are not just patient organisations, but they also come from health professional groups and from manufacturers, pharmaceutical industry, and anybody with an interest in the topic. But they have to be a national organisation. That's our only limitation on who can take part. The individual patients on the group are very instrumental in helping us shape the final recommendations, including the version for patients and the public, again, which I will come back to and talk about in more detail in a moment. But they are crucial in making sure that the language that we use when recommending best practice is patient-focused and keeps the patient at the centre of the discussion. A lot of times there is an assumption that perhaps the development of the guidance is the end point. And sometimes my team and I have to remind people that the end point of clinical guidelines is to try and improve patient care. And sometimes people forget that is the ultimate endpoint, and they just see the end of the guidance as the final thing. But actually, getting the guidance into practice, supporting implementation, is a crucial part of what we do. And we are increasingly seeing individual patients, patient organisations, and also local patient involvement initiatives within hospitals are looking to help us support the implementation of our guidance. But again, I will come back to each of these points in more detail. So, we have a number of different ways in which we involve people. We have individual membership of all of our advisory bodies, whether they're standing committees or individual guidance development groups. And we have a minimum of 2 patients or carers on each of these groups. Usually we have 3. And we have had up to 6. But as I think was indicated on a slide from a previous presentation, the proportional relationship of the numbers of patients compared to the numbers of health professionals is quite low. But we feel as a matter of principle and a matter of good academic good practice as well, having at least 2 people to speak from the patient perspective is crucial. We consult widely with patient and voluntary organisations, as I've already said. We also have the opportunity for individuals to come and give personal testimony to the committees. They may not be formal members of a group, but they can come and talk about their own personal experiences, and that will be taken into account when the recommendations are drafted. I'll just skip a point. We also produce versions of the guidance for patients and the public of every piece of clinical guidance that we produce. Now, to go back to the point about our Citizens' Council, I haven't done a separate slide about this, and I'm very happy to talk about it in more detail at the end if you would like me to. But just in a nutshell, the Citizens' Council is neither patients nor carers. It is are made up of members of the general public, citizens